Okay, so we come to the last session of the day. It's the free paper podium presentation. I'm happy to invite Dr. Dharit Mehta and Dr. Pranav Rathi as conveners, and Dr. Prashant Sonavane and Dr. Prashant Gedam as the chairpersons for this session. Please take it ahead, sir.
Hello. May I invite the first speaker, Mr. Ashraf Shaikh. CT morphometric analysis of medial femoral condyle.
Good evening, everyone. I'm Dr. Ashraf Shaikh, Assistant Professor at Department of Orthopedics, KIM Hospital. And I'll be talking about a study on CT morphometric analysis of medial femoral condyle, where we compared the UKR implants to the Indian knees. So our aims and objectives were to compare the dimensions of the medial femoral condyle of the Indian population to that of the standard size femoral components of the commercially available 3 unicompartmental knee arthroplasty implants. And it was also to find out about the most common sizes of the femoral implants that best fit the Indian knees. It was a cross-sectional analytical study. We conducted CT scan of 100 skeletally mature knees, and these patients underwent CT scan of their knee for various clinical indications, which excluded pathologies that could alter the morphometry of the medial femoral condyle. For example, in this CT scan, you can see the proximal tibia fracture, whereas the medial femoral condyle is intact and normal. The implants that we used for comparison were Link Sled, Depu Sigma Uni, and the Smith & Nephew Journey implants. The steps used for morphometric measurements of the medial femoral condyle were, we drew a line along the posterior femoral cortex, which was corresponding to the posterior peg of the UK implant, a line along the distal femoral cortex perpendicular to the posterior femoral cortex, and since the minimal resection was 6.7 mm distally, we drew another line that was 6.7 mm proximal to the distal femoral cortex. We also drew 2 lines transecting the latter line at the anterior and posterior femoral cortexes, which is line 1 and line 2. And the distance between line 1 and line 2 was used to compare the different conventionally available implant sizes. So the concept of optimal fit and overhang, as we can see in this on the photo on the left hand side, the articular cartilage that is eroded, that is a part that needs to be replaced by the UKR implant. M stands for medial, L for lateral, proximal is the femoral part, distal is the tibial part. And if we have an implant that is having a medial overhang, so this is the part where there will be medial overhang of the implant, and which will lead to medial knee pain and medial structures irritation. On the other hand, in scenario 2, if you have anterior overcoverage, that would lead to patellofemoral stuffiness and increase anterior knee pain. The third scenario, which is lesser of the 2 previous devils, is undercoverage, where this part of the eroded cartilage is not covered, and that would cause reduction in prevention of knee pain. So in our study, there were 56 males, 44 females, with a male to female ratio of 1.27:1. The mean age was around 43.28 years. The average mediolateral diameter was 20.99, and the anterior posterior diameter was 43.56. The Link Sled implants, we found that the best fit was small in 43% of the patients. That was followed by size of medium small in 35% of the patients, and medium in 16% of the patients. In no patient was the large size required. Depu Sigma Uni implants, size 1 was the most common one in 38% of the patients, which is followed by size 3 in 25% of the patients, and then size 4 in 13% of the patients. Smith & Nephew Journey implants, the best fit was in size 2, which was in 30% of the patients, size 3 for 27% of the patients, and size 4 in 15% of the patients, size 1 in 12%. And we defined overhang as an anterior posterior fit of more than 2 mm over and above the femoral condyle, which is the general accepted definition of overhang. And in our study, we found that femoral overhang was seen in 6 Link implants, 12 Depu, and 8 Smith & Nephew implants, in spite of comparing the knees with the smallest size of the femoral component available. So in conclusion, we found that the small size in Link was the best fit for Indian knees for that company, size 1 in Depu implants, size 2 in Smith & Nephew implants, and also an important finding that a proportion of Indian knees will have overhang of the femoral component of UKR, because the medial femoral condyle of some knees is smaller than the smallest size of the smallest femoral component, which in our study was 6% for Link, 12% for Depu, and 8% for Smith & Nephew implants. Thank you.
Yeah, when you say Indian study, I mean, you really studied, it was an Indian, right?
Yes,
You
yes,
said
yes,
Indian.
yes, yes.
When you studied the population from Western zone all over the India.
No, no, only the patients that came to our hospital.
Yeah, I mean, when you
Indian
see,
patients.
when you say that it's an Indian thing, I mean,
Yes.
the size of the implant, I mean, the size of the medial femoral condyle will vary a lot if you go to north, if you go to far east and south. So, will it be right to say an Indian study or just a Western?
So possibly that could be a limitation of our study, where we did not divide the study into on the basis of regions in India,
Yeah.
but we just took it based on Indian population. So that's probably a limitation of the study. But most of our patients usually are from the Western region, so we could probably extrapolate this data to the Western the Western region people more.
That will be the.
Yes.
Yeah.
Yes, sir.
We are in Wiroc. We are not in Ireland.
Good. Congrats.
Thank you, sir.
Please collect your certificate. Jairam bhai, please.
Good evening, Chairman. Good evening, conveners and my dear colleagues. I am Jairam Jagiasi. I will be presenting on spinal tuberculosis, role of MRI in deciding duration of anti-cox therapy. Now, all of us know that TB spine is the most common site for extrapulmonary tuberculosis. It is mainly managed by giving patients anti-cox therapy, but the most challenging part is when do you stop anti-cox therapy? Like the patients, once they are started on anti-cox therapy, depends on their symptomatic recovery and symptomatic relief, depends on ESR, CRP. We decide the duration of AKT. Now the aim of the study was to evaluate the resolution of TB spine on MRI images. And this MRI is also going to guide us the duration of AKT and deciding the end point of AKT, like when do we stop anti-cox therapy for these patients. We had 62 patients included in our study. The study went on for 5 years. We did follow-up MRIs for all the patients. Like the MRI was done starting the therapy, then every 6 monthly for up till 12 months, and then after that every 3 monthly till the end of therapy. Now the inclusion criteria was the patients having TB spine which was diagnosed by tissue diagnosis. Like we don't want to miss out any just on MRI, but we did a tissue diagnosis for all the patients, and patients who were positive on tissue diagnosis were taken in this study. All the age groups were included, and patients who give consent to complete the AKT as per our regime, they were included. The exclusion criteria were patients with associated HIV or any immunocompromised status. Any MDR tuberculosis were excluded, and patients who were not compliant to take AKT were excluded from the study. Now what are the disease characteristics? Now generally we spoke to the MRI guys, and there were classically 4 types of disease characteristics which they reported to us. Now these 4 were divided into 2 groups. One was which was showing completely healed on MRI spine, and the second was near complete healing. So these were the patients who were doing good, they were responding. Whereas the other extreme group was partially healed and no healing seen. That were the other groups. Now what do we mean by this completely healed and near complete healing? Because many times the radiologists just write on the report, it is completely healed or it is near complete healing. So whenever there is resolution of marrow edema, the destroyed areas of bone gets reconstituted by fat or calcification, or whenever there is resolution of the paravertebral or prevertebral collections. The second extreme group was the partially healed and no healed. So whenever there is no resolution of marrow edema, the destroyed areas of bone did not get reconstituted by fat or by calcification, or there was persistence of prevertebral or paravertebral collections. They were categorized into non-healing groups. The results were, we had 62 patients, out of which 42 were females, 20 were males. The age group was from 18 to 65. Predominantly, we had thoracic spine, more cases, followed by lumbar and the cervical spine. 8 patients had skip lesions, and out of 62, 36 required surgical decompression as per the middle path regime. Now this, you see the age group, commonest age group was between 21 and 30 years. Gender, females were more common, and the level of involvement was dorsal more, followed by lumbar and the cervical. Now, MRIs were done every 6 monthly, 6 months, 12 months, and depends on the further recovery, the patients were subjected to 3 monthly MRI till the end of therapy. Now, our results at 6 months showed almost 49% of the patients showed near complete and complete healing, whereas 51% of patients didn't show any resolution or they showed partial resolution. So, at 6 months, only 50% of our patients showed healing. At 12 months, 68% of the patients went to near complete healing, whereas 32 patients were still having no signs of healing. So these patients were further continued for 18 months and 24 months, where they healed. Coming to some examples, this is a MRI pre-therapy at 6 months, 12 months, and at 18 months, which showed complete resolution. The other case in which this patient showed resolution at 12 months of AKT, which this patient was operated. Our conclusion was the anti-cox treatment beyond 12 months in spinal tuberculosis was continued as per the MRI findings, and till the healing continued, they were given AKT for 18 to 24 months, and it is recommended to evaluate the spinal TB lesions clinically by MRI and document the healing after 6 months, 12 months, and further till the end of therapy. Thank you so much.
Any questions?
Sir, I just wanted to know that this MRI was studied by the orthopedic surgeon or the radiologist?
Radiologist, yeah.
So did he compare the previous MRI and then he gave that? So do you think it might be biased that they were comparing with the previous MRI?
No,
you know,
fact,
6 months old MRI
right.
and now you see some improvement. So there is always this
bias. Yeah.
Do you think there is a bias in this?
Right, because they had on MRI panel, they had 4 radiologists who were looking at these MRIs and reporting.
Okay.
And the MRIs, they were comparing them right from pre-therapy, and every 6 months MRIs were done. So they had all the records with them.
Okay.
I have one question.
Yeah.
In the AKT, was streptomycin included because it was spinal?
HRZ, no.
Many times, even after 18 months of AKT, MRI shows complete resolution of disease.
Right.
But I have seen a couple of my patients, particularly young girls, they fail to gain weight.
Okay.
Weight gain is not there.
Right.
And the deep tenderness clinically is still there.
Right.
So what is your take?
As far
MRI
as
shows complete, so I'm confused whether to
stop the AKT or to continue. Yeah. See, if the MRI shows lesion which is healed, you have to stop AKT, but then you have to also look for why the weight is not gaining, because that is a very parameter which goes against stopping AKT.
Sir, many people say that the MRI findings lag behind the actual patient's recovery rate.
Right.
So don't you think using an MRI would lead to giving the patient more duration?
AKT. Yeah, I agree with you, because last Wiroc, Dr. Samir Davli presented a paper in which he said there is a lag when the AKT actually works, but the MRI is still showing the lesion. So in fact, I agree that we have in fact given them 3 months or maybe 6 months more AKT. Because initially when we started this project, this is a 5 years old project. The RNTC guidelines were 6 months in which they had come up with a short therapy. Then now currently they are saying 12 months. So now suddenly the chest physicians have started giving AKT for 12 months. But this is what actually concluded in the study, because at 6 months only 50% of them were showing response. So I agree, we are giving them more AKT as per the MRI.
Sir, excuse me.
Yeah.
Sir, for BMC, we have to refer all patients for RNTCP for medicine.
Right.
After 12 months on MRI basis, they will not give. So what should be done?
So that's what we have to write, because finally it goes on our word and the chest physicians, this thing, on their word it goes. Whatever you advise them on MRI, if the MRI is showing there is still persistent lesion, they give the AKT for them.
Okay, sir. Thank you.
One last question. What about the patient who required instrumentation in spinal tuberculosis?
Right.
How would you judge
MRI?
this endpoint? Because instrumentation will give you a lot
Yeah,
of
we have this
artifacts.
Mars sequence in which they have this
have-
metal artifacts resolution.
Aren't you doing PET scan for this, which is more...
PET scan we are not doing. PET scan is very expensive. In fact, that is the second project we are going to do because
Yeah,
PET scan on
FDG scan,
Right,
fluorodeoxygen is glucose scan. And
because
it will
from
give
Delhi
us-
people are doing PET scans and then
Yeah,
they are stopping
yeah.
the AKT. Yeah.
I mean,
That is maybe the limitation of study. PET
Yeah.
scan we have not done.
thank you very much.
Thank you so much.
Jairam, collect your certificate. May I call Dr. Sheth? He's going to speak on robotics.
So I see we have a mixed audience. I'm going to speak about my learning curve of my first 100 robotic cases using the Smith & Nephew Cori robotics platform. Doing the arthroplasty and comparing it to whether it takes more time compared to conventional surgery and if the robotics platform is able to execute what I want to plan. So knee replacement essentially consists of 3 steps. That's exposure. And then we need to see what parts of the knee are worn out. And only those parts that are worn out need to be replaced. So the bone cuts are such that the unworn parts, that means the cartilage that is intact, needs to be cut just so that it's exactly replaced by the component. This in a robotic system is done through 4 steps. 1, we map out the knee. That's move the pencil over the knee so a 3D model render is created. Next, the implants are superimposed on the 3D model and we can check what bone cuts, what of cuts on the tibia and the femur can be taken. Once the plan is fixed, exactly that much amount of bone can be removed by the execution tool. And once everything is in, there's a post-surgery confirmation on the screen. So in the last 18 months, I compared the 100 conventional knee replacements versus the first 100 robotics cohort. We used a tourniquet starting from the incision to cement setting, a subvastus exposure for all knees, a CR or a PS knee depending on my understanding of the soft tissue balance, used a Smith & Nephew lesion or an Anthem prosthesis for all cases, and the order of the cuts irrespective of conventional or robotic surgery was distal femoral, proximal tibial, then the posterior femur and the other femur cuts. So how we planned was, we look at all knees and just try and divide them whether they are into varus, neutral or valgus, and then try and see the joint line obliquity, whether it's distal, neutral or proximal. This is a classification, CPAC classification, where all knees are divided into these 9, and most varus Indian knees are in a CPAC 1 or a 4, where you can see there's varus, and the joint line is either parallel to the ground or it's apex distal. So I know this is a busy slide with scanograms that you can't really see, but all preoperative scanograms can literally be classified into one of these 9. We are checking the LDFA and the MPTA and calculating something called as an arithmetic HKA. That means where was the knee before the arthritis happened, and we want to get all knees after the knee replacement to that spot. So what we measure was HKA, LDFA, MPTA, tibia slope, femur flexion, all of this before surgery. Then do the knee replacement, see it on the robotic platform screen before the end of surgery what we've achieved, and then do the post-op scanograms and check that what we've achieved, is the robot actually getting there? And the methods to do that was, for an index case, for example, this is the planning screen. So where I'm cutting 9.5 mm from the lateral distal femur, because there's no wear on the lateral distal femur. I'm cutting 8 mm from the medial distal femur. This is a varus knee, so there's some cartilage wear on the medial side. That's the posterior femoral cuts. And on the right hand side, you can see a size 4 femur and a size 3 tibia. This is the planning. And then once you execute, this is the end screen. And what I'm checking here is, okay, finally I've put the tibial component in 3 degrees of varus. I put the femur with an LDFA of 90, that means it's a mechanical 0 degrees, the femur in 5 degrees of flexion, and the tibia in 4 degrees of slope. Eventually, I've achieved a 2-degree varus. Now I went on post-op scanograms and measured these. And what we know at the end of my 100 cases is that my robotic times started reducing from the 16th case. My conventional surgeries on an average took 50 minutes. And even after 100 cases, I get much faster in the robotic cases, but my average surgical time with the robotics cases between 65 and 70 minutes. As far as the alignment accuracy is concerned, the HKA, the LDFA, the MPTA, all of them, whatever I achieve on the final screen is what I get on the post-op scanograms, except the system does not understand the tibial component slope very well. So if I want to put the tibial component with a 5-degree slope, on my post-op X-ray I am seeing that the component's flat. So maybe the system does not understand tibial component slope so well. Points worth noting, 4 cases the system went wrong, so I had to convert to conventional. No complications as such seen to note of in the first 100. And I couldn't really match my conventional times with the robotic system even after 100 cases. So to conclude, the learning curve of course means that you get better at the technology. So from the 16th case, I get faster using it, but it still is slightly longer than reported in current literature. And the system's accurate, except for maybe checking the tibial component sagittal slope. Thank you.
Good job. Any questions? For all the cases, you had deflated the tourniquet
Yes,
after
before
cementing.
closure.
After cementing.
Yes.
Hi, just a thing. When you said that in 4 cases the system went wrong, what happened? How do you make out that the system is wrong?
No. So there are snags. So for example, you can't move from the planning screen to the execution screen because the system is saying, I can't pick up the markers. So it's a technical problem there. So for example, one of those screens, we had loss of electricity. The system's supposed to reboot, but it didn't reboot.
Okay. And do you always keep your conventional set of instruments?
It's always there, of course.
To cross-check with the system, even intraoperatively.
No, that has already been done. So that's why they came out with the system, right? So when they release a system into the market, they've already done this. So then, of course, if you have your individual paranoia, then you will do it for your initial cases and see. But most of this paper actually tells you that since you're able to achieve eventually what you're planning, then why do you want to cross-check again with your conventional jigs case to case?
Any more questions? Sir?
I don't do navigation, I don't do robotics, I do the simple conventional TKR, and I'm very happy with it.
Okay, fine.
Gold is gold for us.
I'm not that trouble. I think the only role is for these complex extra-articular ones, or where really the deformities are bad, post-fractures, where you could navigate with shorter rods. I think that is where... But
point of contention. So my understanding of this system currently is it works very poorly in complex cases and cases with osteophytes. Unlike normal understanding and where you see the role, it works best in knees that are just about worn out. So it works best for doing a unicompartmental knee replacement. It works best for the unis which now have patellofemoral arthritis. Hence, you can kinematically place the prosthesis perfectly well using the robotic system. So if you understand that all knees don't need to be mechanically aligned, then the lesser worn out knees need a robotic system to place the components in kinematically. Whereas bad knees, varus knees, you're going to align them mechanically, you might as well do them without the robotic system as well.
You know, with all this, what is not clear is, at the end of the day, longevity and the function at the end of 6 months to 1 year. See, look, I was a part of the study when I was in the UK, where navigation was just coming in. And this was at the Royal National Orthopedics. So in one unit, we were using those navigated knees, and the other ones we were doing box standard conventional TKRs. We looked at the data at the end of 1 year. So clinically, patients were happy with your box standard TKR. The range of motion was good. In fact, even on the navigated ones, when you look at the post-op standing x-rays, you still feel there's an odd tilt or an odd slope. So although what you think on table, you've got it bang perfect, you'll get nasty shocks post-op. So it's not 100% foolproof. And we didn't find that the time invested, of course the time shortens with time, or the costings. Now, for the interest of the audience, what is the extra cost which you are charging for the use of robotics?
That's a great point again. It's a great question. If you are using an institutional robot, then the administrator or the institution decides what you want to put in as a robotic rental. I own the robot as a surgeon. So if I charge a patient 1 lakh for my surgical charges, I just absorb the robotic rental and don't charge anything for the robotic surgery at all. If I am earning less and I'm operating at a hospital where I want to put in a robotic rental, I can go ahead and do that. Once you own a car or a taxi and you want to lease it out, you decide whether you want to give it off free or not. So I don't impart any extra cost to the patient. Then how, if I see value in the system, then the question then doesn't go to the patient at all, whether it's value for money. It's for me to decide whether it's value for money. I am giving value to the patient. For me, value is more important than value for money. Hence, the robot works in my hands.
Thank you, doctor.
Thank you.
Thank you.
We'll call you for all our general ward patients.
One comment. A hospital in Kurla, the regular TCAR package is 3 and the robotics is 4.
Look, you are looking at it differently. I know we are digressing, but sometimes I feel that the commerce, which is driven by the industry, is blinding the surgeons as to what you need to use for and what you don't need to use for. Now, look, at the end of 1 year, put up a paper showing your function.
Exactly. So I promise you, next Wiroc, that's where my 2-year functional outcomes will come out. And I tell you that will be the paper where we'll go on to discuss, okay, this is published now and I'm presenting it simultaneously, and see that's where value works and maybe not just discussing value for money. Okay?
Thank you.
Thank you.
May
That
I
was a
invite-
nice presentation. Just accept this.
Yeah, may I invite Dr. Pratik Tawri?
Thank you, Chairmen and Conveners. Good evening, everyone. So I'm presenting a neglected, untreated ACJ dislocations, a simple, cost-effective technique, a study done at Bombay Hospital with my senior consultant, Dr. Parag Mochi, sir. Acromio-clavicular injury accounts for 8% of all the dislocations. Its overall incidence is 3 to 4 per 1 lakh in the general population. Of them, majority comes from the sport activities, and the true incidence is unknown because they are underestimated because many cases go undiagnosed and untreated. We all are very well aware with the Rockwood classification. Here we are focusing mainly on Rockwood type 3 and type 5 of dislocation. Going back to literature, there are various methods and techniques described for the ACJ dislocation. Fixing with Bosworth screw, the dog bone, hook plates, K-wires, coracoacromial ligament transfer, coraco-clavicular ligament reconstruction, distal clavicle excision, various arthroscopic assisted techniques, etc. However, there are still no clear consensus on which treatment is considered to be the best. We had 12 patients who had delayed presentation of ACJ. All of them were type 3 or above. Of them, 10 were of type 3 and 2 were of type 5. All of these underwent the surgical stabilization with our technique, and they were assessed at 3 months, 6 months, and 1 year using the acromio-clavicular instability score. We do this technique on a beach chair position after appropriate anesthesia, and there are 2 small incisions given. The first incision is over the coracoid process, a vertical incision, and the second incision is lateral over the lateral end of clavicle. Through the first incision, the coracoid tip and the base is exposed and the soft tissues are cleared. The marceline tape is then passed underneath the base of the coracoid with the help of a mixtur's forceps. Then the second incision is taken over the lateral end clavicle, and 7 to 10 mm of the lateral end clavicle is excised. With the help of 3.2 mm drill bit, we drill the clavicle from superior to inferior. Then one limb of the muslin tape is then shuttled out from the second incision posterior to the clavicle. Then it is passed through the tunnel what we have made, and it is brought back from beneath the coracoid process. The traction is applied to that muslin tape, and it pulls the clavicle from back to front as well as from superior to inferior, thus reducing it from in both the vectors. And then it is tied to the other limb, and at least 4 knots we prefer. After satisfactory job, we give a wound wash and a local analgesic infiltration for post-op relief, pain relief. And the post-op protocol is we protect the patient in arm pouch for about 3 weeks, then we start the physiotherapy, and overhead movements are allowed after 5 weeks. With this technique, we achieve minimal dissection, no hardware, and thus no donocyte graft morbidity. This is the pre-op and the post-op X-ray. This is how it looks. This is the case, clinical photos. At 1 year follow-up, she was having good range of motion, full movements were achieved, and we give them a good cosmetic scar. This is an auto rickshaw driver. At 5 weeks of follow-up, he was achieving a good range of motion, full range of motion. We do have complications. In our series, we had no infections or shoulder stiffness. However, one patient had moderate re-superior migration with no pain, but there was full movements. So clinically, he was good. Radiologically, there was a complication. At the end of 1 year, we achieved a good functional range as well as pain scores. Using the ACJI scores, it was increased from 63.7 pre-operative to 81.4 post-operative. And all patients are comfortable in performing their daily activities and vocation at the time of follow-up. We can conclude that this is a cheap technique. The muslin tape costs about 900 rupees. It is a quick technique. The operative time is averagely 35 minutes, and durable technique. There is minimal analgesic requirement, and the post-op hospital stay is just 1 day. The range of motion is very swift once they cross 3 weeks of post-operative period. These are few happy faces. Thank you.
Question from a knee surgeon. What is the function of the acromio-clavicular joint in a normal patient? Like, does it have any role in normal shoulder function? And considering you remove the lateral end of the clavicle, does that affect shoulder function? So in a normal patient, does AC joint have any function?
AC joint, if we do not remove the lateral end of clavicle after the dislocation, after the dislocation, there is fibrocartilage development, and which degenerates, and therefore there is arthrosis development. If we do not remove the lateral end of clavicle, then the arthritis will develop and the patient will be painful. So that is why.
I know where you're coming from, but does the AC joint have any function?
Yeah. Okay. So if you look at the kinematics of the shoulder joint, your ACJ comes into play when you're doing cross adduction at 90 degrees. Okay. So for this movement, they will achieve, but what happens is you will lose some strength. Now the whole debate is as to when you get these, these are late dislocators or patients who have elected not to have surgery prima facie and now they've changed their mind. So the question in my mind was, if you relocate this back, what is the native state of the fibrocartilage? If you put it back in, is this fibrocartilage viable? It has been out for more than 6 weeks, some of them are 3 months, some of them are 5 months. So this is non-viable. So one procedure, I excise it so that the fibrocartilage is out. And the reason we are waiting is it's a static restraint. But when you let them heal over 5 weeks, you get sufficient scar tissue. So that last guy, he's actually an auto rickshaw driver. He came to me saying that I've already started driving. So the bottom line is it's a safe procedure. It's a cheap, durable procedure, consistent results. And you know, when I look at the cross adduction, it's not any weak at all. And all of them, you know, they are not elite athletes. So they're all very happy. And you know, there's no hardware. You get that Arthrex dog bone costing 70K. You know, you'll get 3 patients done in that same one dog bone price. So it's a very cheap, useful technique.
Any chance of slippage from the coracoid side, you know?
We are passing it through the tunnel. So from the coracoid side, no, sir. Because the base at the base of the coracoid, there is a short head of the biceps attached. So we are passing it from beneath the coracoid. So there is no chance of
in your series any
no, sir.
complication like
No,
that?
I think we are short on time. We'll have to go to the next one.
Thank you, sir.
One last quick question, if you may. Okay. For the benefit of the beginners, when you're dissecting near the clavicle, how much to excise sometimes becomes a bit of a challenge, especially when you're facing the learning curve. So any advice or tips on how to prevent a subclavian injury? Because trust me, everybody's hands are not the same. So either from you or from Parag.
So it is actually very safe. Look, you are going at the lateral end. You're far, far away from the subclavian vessel.
Any landmarks,
So-
where to stop?
So what you do is, you'll feel that the clavicle is out, right? It'll be under the trapezius, so it'll be up and high. Then you try to push it back and see where it's coming in. And then you make a small incision just on the lateral end of the clavicle. Now, if it's a small lady, I take out only 7 mm. It's a big burly character.
That's what I was looking for. How much would
Yeah,
you say
about
as a
7 mm you can
5 to
take
7
out.
mm?
Yeah, that's more than enough.
Thank you.
Yeah, would you please collect your certificate?
And till then, can I have Avinash up for his presentation?
Good evening, everyone. This is Dr. Avinash presenting outcome and analysis of patellar figure of a tension band wiring without K-wire anchorage. So, as we all know, patellar fracture consists of the 1% of all the fractures, and surgical indication are like more than 2 mm of the articular gap, and if there is an extensor mechanism disruption. And the function-wise, patella gives the momentum strength around the knee joint, that is around patella, it increases by the 30%. And it also gives a patellofemoral joint reaction. That is, when you go downstairs or the downhill, it controls that walking movement when you go downhill. So that control moment is there. So as mechanics-wise, during flexion, there is 7.65 times increased force on the patella in the flexion. So the method for the fixation of the patella needs to be adequate to sustain that extra pressure. So the conventional with the TBW and K-wire, there are few complications which includes pain, joint irritation, migration of the K-wire and protrusion of the K-wire. So being a sesamoid bone, the union rate in the patella is more than 95%. So there are various method practiced currently, which is standard AO method as we know. So it consists of the maybe encirclage or not with the figure of 8 tension band wiring around the 2 K-wires. So recently they are using cannulated screw also, where we have the horizontal figure of 8 tension band wiring. So the original pair 4 technique was introduced in the 1974, which has a circle of 0 anterior tension band wiring, which was direct purchased in the quadriceps tendon as well as in the patellar tendon. So on the basis of fine element analysis and the model studies, they have figured out that figure of 8 tension band wiring has more stability than the circle of 0. So we included 38 patients, OTA 3-4C types of fracture. Age group was varying from 22 to 70 years. And all of them were managed by the direct purchase in the quadriceps tendon and the patellar tendon. So this is a schematic diagram. And we followed up this patient starting from the 1 year to 3 years. So the outcome we evaluated from the on the basis of the ROM, articular reduction, and the healing time, and the Boschman score. So this was the first case, 55-year-old female with 3-4C type of fracture. We managed with the R method, and patient at the end of the 2 years, patient had a full range of motion, no complication or no physical pain whatsoever. So the second patient was a 48-year-old male with 3-4C of the fracture. We managed with the same method, and the patient had a complete ROM without any complication. The third patient was the 68-year female obese, which was managed with the figure of 8 tension band wiring with encirclage. Patient had around 115 of the range of motion without any complications. So results were as such. The mean age of the patient were 45 years. The 35 patient out of 38 had a 90 degree of range of motion at the end of the 4 weeks. So 2 patients had developed a knee stiffness, which was resolved around the 8 weeks with the enough physiotherapy. And the 7 patient had an extension lag, which improved around the 12 week with the physiotherapies. And one patient had developed a superficial infection, which we managed with the oral antibiotics, which was resolved. And the fracture, on average, united from the 11 to 15 weeks, that was around the 12.5 weeks. So there was one case of implant removal at the end of 3 years. We found out that the superolateral corner, there was a break in the construct. So that also the patient had complained of the pain, so we had to remove his hardware. So that was the one question. One patient that comes out to be around 2.42%. So yeah, no incidence of the union problem, so 0 non-union. And the Boschman functional scores comes out to be 28.5, which is excellent. This is a range of motion over 4 week, 8 week and 16 weeks. So at the end of 16 week, we achieved a 30, in the 30th patient, we achieved around 130 degree of range of motion. So to conclude, so this method gives good functional outcome and less complication. K-wire are not used, so those complications are nullified. Useful in a simple as well as comminuted fracture, so good outcome in both. Rate of implant removal is less. So limitation being cannot be used in the tendon disruption, maybe patellar, the quadriceps tendon, and obviously needs a larger size of data and the longer follow-up. So this was to quote, this was a 2017 study which actually calculates the rate of implant removal in the AO technique. So it comes around 50%. That is here they have found it to be 46%. So they also quoted that the force preventing the dislodgement of the tension band may originate mainly from the tendons rather than the K-wires. So this is a similar study which had the higher, were treated with the K-wire, and this is the last paper I want to quote. It was in 1990 by the Curtis, who demonstrated in the lab that the modified tension band wiring, which was figure of 0, against the MTB against the pay-for technique. So the pay-for technique around gave good stability until the 25 kg of the weight load, whereas the modified tension band wiring failed around the 18 kg of the weight. Thank you.
Any questions?
Congrats. Any questions from the audience?
What about comminuted? You mentioned about only that it showed only the transverse fracture.
No,
what about comminuted?
3-4C includes transverse as well as comminuted. Sir.
Yeah, comminuted also
C1,
you will
C2,
recommend
all,
this.
yes. So that round circulage is for that containment of all the comminuted fragments.
So my only question is, if you're not using K-wire, did you change your post-op protocol, knee brace for a longer time or anything like that?
Not really. Initially we kept it as patient base. So we have to go like patient's comfort wise also. There was one line I quoted that they mentioned the force which contains the figure of a tension band wire ka force means it will give, that maybe came from the tendon rather than the K-wire. That last, I quoted the first article. So it is more likely that the force we are getting, that is from the tendon itself.
Yeah, so
last question.
Just a comment. You know, this technique has been there for a long time.
Yes, right.
In fact, when we were interns at KEM, I remember seeing Dr. Dharit for poor patients at KEM. Forget tension band wire, he would use number 5 ethibond.
Yes.
And he would say this would heal, but you had to repair the transverse retinaculum ligament very well. Yes. And he would put them into an extension splint. Those days he would put them into a plaster cylinder for 3 weeks. So if you don't use K-wires, I'm actually surprised with that paper, because the AO studies do show that when you use a TBW with K-wire, it's a stronger construct in terms of getting flexion early as well. So you can use this. It has been there since sliced bread. And as I said, people were using it earlier just with ethibond. Forget even the metallic wire. So it works, but you have to go slow with your rehab.
Yeah, sure. That was the time. Actually, they are using, nowadays they are using fiber wire also for the, it's giving the good outcome with the less complications.
Thank you very much. Would you please collect your certificate from Dr. Gedam? May I invite the next speaker? Dr. Shalin Shah.
Good evening, everyone. Today I'm going to talk about dosing of surgery for shoulder sequelae in obstetric brachial plexus palsy. So the spectrum of clinical presentation of children who come to us with obstetric brachial plexus palsy is varied. They have a varied limitation of abduction and external rotation limitation clinically. They have a varied presentation of the radiological aspect of the glenohumeral joint deformity, right from completely normal glenohumeral joint to a completely dislocated one. And the Narakas grade, which is the nerve root affection, also varies, right from just a classic Erb's palsy to a complete nerve palsy. So conjoint tendon transfer with or without anterior releases has been said to be the workhorse for reconstruction of these shoulder sequelae. But a one key fits all lock for these varied clinical presentations, varied radiological presentations, and varied nerve root affections would not suffice. So with these things in mind, we aim to document the varied presentations of the children with obstetric brachial plexus palsy coming to us. We try to evaluate an algorithm based on the tangibly measured parameters, and we try to evaluate the outcome of these algorithms in our hands. So it's a retrospective study carried out over a period of 5 years. Pre-operatively, we use the modified Mealy score to score the shoulder function, which is a comprehensive score for shoulder use in day-to-day activities. We recorded the Narakas grade and we recorded the Waters grade, which is the radiological aspect. And we use pre-operative and post-operative abduction range, external rotation range, and modified Mealy score to grade the outcome. For the dosing of surgery for the posterior part, which is the tendon transfers, we decided to do a single tendon, which is the latissimus dorsi transfer, when clinically there was a preoperative internal rotation weakness or a single range deficit, when there were minimal changes in the glenohumeral joint and there was greater neuronal recovery. We decided on doing a conjoint tendon transfer when there was severe internal rotation contractures, when there was poor abduction and external rotation range, which is both range deficits, and when there was radiologically a higher glenohumeral joint, which is subluxation or dislocation of the glenohumeral joint, and when there was lesser neuronal recovery. For the anterior part, which is the releases, we considered only a fractional release, which is the pectoralis major release, when the passive external rotation range was between 30 to 45, and we considered a radical release, which is pectoral release, coracohumeral ligament release, and a joint reduction whenever required when passive external rotation range was less than 30. So based on these, we could enroll 30 patients in our series. The mean age was 3 years and Waters distribution was as follows. The sex distribution was equivocal. The laterality, the right was majority of them, and Narakas distribution was as follows, with N2 being the majority of the patients. So in the Narakas 1 subgroup, which is the upper plexus palsy, we had 8 patients. All of these 8 required anterior releases, with just 1 requiring a fractional lengthening, rest all requiring radical releases. And a majority of them, which is 7 out of 8, required a conjoint tendon transfer. And we could achieve a mean abduction improvement of 72 degrees, passive external rotation range improvement of 27 degrees, and a modified Mealy score improvement of 4.6. For the second subgroup, which is the Narakas 2, we could enroll 17 patients. Anterior releases were required in 10 out of these 17 with equal distribution of the radical and the fractional releases. And isolated lead dorsi transfer was required in 9 and a conjoint tendon in 8. And we could achieve a abduction improvement mean of 59 degrees and a passive external rotation range improvement of 26 and a modified Mealy score improvement of 3.8. In the third, we combined the Narakas 3 and 4, which is total plexus palsy, and we could have 5 patients. Out of these, anterior release was required in 4, but majority of them was just fractional lengthenings. And isolated lead dorsi transfer was required in 3, conjoint tendon transfer in 2. And we could achieve a mean abduction improvement of 56 degrees, passive external rotation range improvement of 26 degrees, and a modified Mealy score improvement of 3.75. When we compared our outcome with what is already published in literature, we could achieve a greater amount of abduction improvement. And the external rotation range improvement, though less, the final abduction external rotation range was equivocal to the already published literature. And based on these, we suggest the following algorithm for management of the various clinical, radiological, and Narakas grade which present to us. So these are 5 different clinical presentations. So if a child has poor abduction and a good active external rotation, we look at the glenohumeral joint, and most of them have a congruent glenohumeral joint. We look at the external rotation range. If it is more than 45, we just recommend an isolated lead dorsi transfer. When it is between 30 to 45, we recommend a pec major fractional lengthening with isolated lead dorsi transfer. When there is poor external rotation active with or without abduction limitation, we next look at the glenohumeral joint radiologically. If it's non-congruent, we recommend a radical anterior release with a conjoint tendon transfer. When it's congruent, we look at the external rotation range. If it's between 30 to 45, we recommend a fractional lengthening with an isolated lead dorsi transfer. When there is no internal rotation contracture, only a lead dorsi transfer is recommended. Thank you.
Any questions from the audience?
Really nice presentation, Dr. Shalan. Thanks. Just one question. When you do an isolated transfer and when you do a conjoint transfer, does your post-op protocol change?
No, the post-op protocol remains the same. We do isolated lead dosage transfer specifically because these patients have lesser tendon recovery because they are higher in the nerve. So in total plexus palsy is where we require isolated lead dosage transfer, or patients with limited internal rotation, this is where we require. So it maintains a balance between the external rotation and the internal rotation. So published literature shows that many of patients develop internal rotation limitation after surgery. And what we have found that internal rotation limitation, decrease in internal rotation after surgery has not been a complication in our subgroup after we have followed this protocol. So post-op protocol is same, but single tendon transfer helps in that aspect.
Thank you very much.
Thank you.
Would you please collect your certificate?
Yeah, thank you. That was a nice presentation by all the participants. And with this, now I conclude this session. Thank you very much.